Now I'm going to go a little bit off script here. I think everyone's had their mains, correct? Over here, this side of the table, this side of the room, nods. Yep, you've had your mains. So I think let's just maybe take a 1 minute break, stand up, stretch, move around, and then in 1 minute we'll just set up for the panel discussion that'll be led by Dr. Sarah Chu. So stay tuned.
Good evening, everyone, for the last part of the day, last part of a very long day probably for all of us here and all those online. The ones online, I guess you don't have the pleasure of enjoying dinner and dessert. Hopefully you've got something delicious at home. So the last part of this evening, we've got a panel discussion, and I'd love to welcome everyone on stage. Professor Charles probably doesn't need an introduction, having just finished wrapping up and speaking to us just then on RSV in adults. So we've seen a lovely spectrum from the maternal program onto infants and then now to older adults. And that's the same way we'll be structuring the panel discussion. The first half will be mostly focused on maternal and infant RSV strategies to vaccinate against RSV in this age group, and then moving to finish with older adults vaccination strategies for the current and future sort of fund programs. Professor Charles tells me that in South Africa, where he came from, a lot of the focus was unfortunately on HIV, TB and trauma, and that took up a lot of the, the needs and demands of the medical staff there. So he's very excited to be here amongst his tribe, speaking to vaccination in adults. And I've asked each of our panel members what was their most recent vaccine that they received and which was their next vaccine that they were going to have. And Professor Charles tells me he has had his Shingrix vaccine and his Fluad. Hopefully I'm not giving away his date of birth. And the next one that's coming up is he's likely to be having the new pneumococcal vaccine for adults. And we're also joined on the stage next to Charles. We've got, I'll just introduce in order of who's sitting there because it's a little bit easier. We've got Haveen Mushi. She's a community pharmacist and proprietor of 2 pharmacies in Victoria with more than 10 years' experience as an accredited pharmacist immuniser. It only takes a minute for you to chat with her and you'll feel her passion for vaccinations just oozing out of her. She's actively involved in the Monash Uni intern training program that supports the development of future pharmacists and is an active immuniser across all age groups. She's recently had her flu shot, and the next shot she's having is, she mentions it's definitely going to be the diphtheria, tetanus and whooping cough booster, but she's also travelling to Thailand, so she might need some travel vaccines. And next to her, we've got Associate Professor Rolf Odem, who is a Melbourne-based GP of over 35 years' experience. He's also a Clinical Associate Professor with the Department of General Practice at the University of Melbourne. He's also had his flu and COVID booster together, and his next shots will be his shingles and probably the pneumococcal vaccine, maybe together. And next to him, we've got Kaz Bellamy, who you can see nothing's going to stop her from coming up onto the stage and being our panellist. She is that committed. She's had her flu shot recently, but her next booster is going to be the diphtheria, tetanus, whooping cough booster. She's an infectious disease and immunisation nurse practitioner with specialist expertise in high-risk, antenatal and travel immunisation, and she's also a current member of ATAGI. So without any further ado, our first maternal infant question I'd like to throw to the panel is, are clinicians still uncertain about the ATAGI guidance or the recommendations, especially around maternal vaccine versus Nirsevimab? Let's throw it to Ralph.
Me first. I love always being first. No, I'm pretty happy, and I must admit, when I say I'm pretty happy, I must admit it's my practice nurse who's incredibly happy. She's got her head around it. So when I say to my 28-weeker, you're due for your immunisations, I'll send you down to my nurse. She gives them everything, so I don't have to think too hard.
Mm-hmm. Sounds like we need to clone this nurse. What have been the other people's experiences? Kaz?
In my experience, it's certainly improved. So I think we certainly noticed a big spike in errors with the introduction of Nirsevimab, but there are still some concerns. There are still, because Nirsevimab is not regularly entered into air because it's not considered a vaccine, which will hopefully change soon. It is it's certainly hard to track, who's had what, and there's certainly errors where products have been given to infants that should have been given maternally and vice versa. So it's improved, but it's getting better, and I think the knowledge is improving.
Now, I know when we had this meeting this time last year, we had about 24, 25 sort of vaccine errors, wrong brands given to the wrong age groups. How many more have there been since, I guess, this time last year? Tough question.
I can't talk in specific numbers, but they are reducing because of increased knowledge, because of meetings like this where people are becoming informed about the differences between the two products, that one is for infants and one is for maternal. I think, once we start adding other products, such as Clesrovimab, which is, potentially another product that will be coming into the infant space, I think that's where we need to really focus on educating our providers, our GPs, our pharmacists, our nurse immunisers, everyone who's involved in vaccines, to make sure that those errors don't happen right from the get-go. And, I think the other thing from an ATAGI point of view is encouraging that the comms that come out to our health professionals are accurate and, plain language in many ways right from the get-go as well.
Mm-hmm. Haveen, has that been your experience in pharmacy? Is there much confusion around the maternal versus the infant program? The customers you see?
There is. I mean, at the start there was a bit of confusion. I do agree with that. But I feel like we're on top of it now.
That's great, because what I'll do is jump into, well, how do you keep up to date with all these changes that are ongoing and will forever continue to come?
Do you know what? The best thing that's happened to us is we've got this consult room that has a computer. Okay? Whenever you're uncertain, you just jump on and you look it up. Because you can't possibly memorise everything. You can't possibly know everything. And we're not just doing one vaccine type. We're doing 8 to 10 different vaccine types, different age groups, different eligibilities. So unsure, always double check. And that's been the best thing for it.
And I mean, that includes when you do catch-up vaccines. I mean, that's when it starts to get really quite complex at times. And again, there's a great little chart that you can use in the back of the immunisation handbook that's really useful.
Kaz, you've mentioned some lovely resources. Any other pointers at all?
No, I think that that it's great. I think the ability to look up the information is there. Is it plain language enough for providers? Is probably a question that I have. I think if you're working in it day in and day out, and you're part of the decision making about what the recommendations are, it's quite easy. But if you're a provider who is not necessarily doing it all the time, is it actually easy to keep up with the constant changes? And there's been a lot in the recent years.
I think it still is quite easy to navigate through that information, even if you weren't to do it every single day. So if you weren't doing clinics every day, the start was difficult, and it was just getting our head around. I agree, the language was quite sort of dense, I must say. But now it's, you know where to look, you know where to find the information, and it's quite quick. Yeah.
I mean, one of the things that worries me a little bit is about the infants who are missing out. We were talking about 40%, up to 40% of children not getting the RSV coverage that they need. And it's a bit opaque. So if I have an infant that comes into me, brought in by dad, how do I know whether the mum was immunised or not? I mean,
How do you know?
well, you don't.
How could you
Yeah.
find out?
Yeah.
Access to air, and so I think maternal vaccinations mandated to be on air. So that's a bit of a no-brainer. Nirsevimab is where it becomes a bit tricky.
Yeah, that's what I was talking about.
Yeah. Nirsevimab not being mandated to be on air because it's not a vaccine, but that will change.
But even to check whether the mum, so if the mum's not a patient of mine, then I usually have to get my nurse to actually log on and then chase it up and do whatever, because it takes time.
It's one of my trying to say it post a lovely dinner and a few drinks. It's one of my pet peeves about air is the difficulty in accessing air for the everyday person who provides immunisations. Air should be just easily, even a read-only version should be easily accessible to anybody very quickly. And so I think that's probably something that we should look to change in the future, is having that as an option for someone who's busy in a practice. It just pops up somewhere because it's doable. It's happening with certain programs where it's just there ready for you to access.
I did hear one of the speakers before talk about, that maternal infant dyad pairing, that hopefully they'll have some data linkage so that we can readily identify the mother infant pairs who might have had one or the other, or mother did receive it but it was within 2 weeks, or still the infant would still need the Nirsevimab passive immunisation as well. And interestingly, at one of our primary care infectious diseases meeting, we were lucky enough to hear from somebody from the government who worked on air, and it is very old technology that we are asking it to do things that it was never set up to do. But these are in place, and there is actually an email address you can send your wish list to.
Good luck with that.
Yes, they're not above my pay grade, but not theirs.
There is currently a review on air at the moment, but it's almost too late, like to try and fix a quite broken program. Hoping nobody's here in the room from HPOS, but it's tricky and it really needs to be fixed, because it's a brilliant idea, that whole of life vaccination program. Nirsevimab and other products like it will soon be accessible to air, but they have to go through the PBAC process to get onto the NIP to then be mandated to go on air. So that adds another complexity to the whole air, the air process, and whether or not it's helpful or not.
Actually,
Sorry,
for
I might
Haveen,
add
I was just
something,
about to
yeah.
ask you, how is it from a pharmacist perspective in terms of access?
Very challenging.
Yes.
Very, very challenging. So we service some nursing homes, and we're talking upwards of 75 to 100 patients for that day that are booked in, and you have to be prepared. So I have someone that sits there, enters Medicare number, checks everything, whether they're eligible or not, goes through, goes back, and if they get interrupted, they get logged out. So it's a huge hassle.
And there's about 47 buttons you have to press once you're logged out to get back in.
Absolutely. Yeah, so definitely an improvement on air would cover that gap.
Charles, is there any data that you hope to see that would help inform, I guess, your practice or, your advice and
Yeah, so
strategy?
my practice is very different because I'm dealing with older people who don't get pregnant and don't have the issue of children, so it's a much easier kind of situation to deal with. But I'm aware of the other issues that have been discussed. It's not that much of a problem with older individuals with the elderly.
Kaz?
I think with the changes that we've had in the older adult program over the years, with the introduction of so many older adult vaccines on the NIP, it's tricky in terms of consent. And, if you're looking at older adults who potentially have other family members that they rely upon for consent for vaccines, that poses another difficulty in the adult space, as well as, wondering whether or not they're actually up to date with their vaccinations via air.
I'm going to challenge you a little bit on it's easy for the older people because I tend to find that my older cohort, don't know what RSV is. They don't know what problem it has. And so when you start talking about it, then do I really need it, doctor? Isn't that a thing that the kids get? And you sort of go through that whole explanation. So whereas pregnant women will have anything to protect their baby. They love it. It's been really good.
Yeah. One of the things we talked about as the group is, do adults know about RSV? And are they amenable, so older adults, are they amenable to learning about RSV? And are they amenable then to be vaccinated? Because clearly we are not vaccinating enough of the elderly population yet.
I'll come back to Haveen because you've got a very positive story to share because we had this discussion. Well, do we even need to start? Do you know what RSV is? So what's been your experience with some of the pregnant women, just to come back to, pregnant and infant RSV?
In the pharmacy setting, we get a lot of, pregnant ladies that come in that are already booked in for the RSV and they just come in and get it administered. Rarely do I get challenged and rarely do I get, a pregnant lady that will come in and say, do you think I need it? Or do you think I should be getting it? You might get the 1%ers of like, can I get your opinion on this? Would you be getting it? But otherwise, I think the doctors and the midwives and the nurses have done such a great job in educating that cohort that it's been really easy for us.
Now, we did see that those numbers were not 100% for maternal vaccination, and obviously the ones that are booking in are self-selected to already, want the vaccine.
But they have been given that education. They've been empowered to know what it is and how it will affect their baby. So I think in that aspect, that piece has been done really well. Whether they've gone home and thought about it and then, booked themselves in, that's.
Is there a difference in your experience between women who might have received private obstetrician care versus shared care or public midwifery models of care in terms of their willingness to receive a maternal RSV vaccine?
I don't know. I don't really have that data.
Kaz? Yeah, sorry.
I think the data clearly shows that whoever their trusted professional is has the most impact on their decision. Overall, many women who are pregnant, their most trusted provider is usually a midwife. In terms of, yes, I'm so sorry.
Okay.
Followed by GPs.
Okay.
But obstetricians are trusted most for overall health advice. But I think it depends who that woman's most trusted professional is. And that could
Just
be
speak
any
into
one
the
of those-
microphone a little bit
That
more.
could be any one of those folks, including pharmacy. But often in the antenatal space, that work has been done prior to them coming to a pharmacy. So the discussions have already been had, which is why you're probably finding it not too difficult.
But can I just say, the elderly have been so difficult.
We might move on to the discussion about RSV vaccines in older adults. We'll segue to older adults, actually. That's a really good point because we've only got about 14 minutes. What's been the most challenging?
They don't know what RSV is. That's been the biggest challenge. You know, you identify that they're 75 and above. I mean, that's the easiest identifier, right? You're at Scripts Inn, they come in, you're like, yes, 75 and above. Would you like you're eligible for a free RSV vaccine. What is RSV? And then you go to explain, no, I've already had my flu. I've already had my COVID. So I think there's a lot of sort of work for us to do when it comes to the 75 plus.
Ralph, has that been your experience or your lovely practice nurses' experience?
Well, I mean, vaccine fatigue is alive and well. I mean, there's a lot to be given. I suppose one of the questions I always talk to the over 75 is, do they care for the grandchildren, or are they going out with the grandchildren? Because when you start thinking, well, you know, when they come over, do you get sick? And the answer is always. And so the question then becomes, well, you know, part of this is the RSV, and you know, as you get older, if you get infected, it's actually affecting you a lot more. So if they tie it in with the family and having a good time with the family, but it protects them, it sort of sways them a little bit. But you're right, the actual knowledge of RSV is pretty poor. I mean, you can relate it to the wheezing bronchiolitis that we used to talk about kids, but that's not relevant to them anymore because they're grown up. And you've got to say, well, you know, this, you know, for people with COPD, heart disease, it actually causes a problem. And, you know, you've got to have that to and from. It does take a little bit more, but yeah, important conversation.
I think Haveen's mentioned, you know, the 75 plus, that's the easy ones to identify. And we've got the NIP funded 60 plus group for the Indigenous and Torres Strait Islanders. Now, Charles, you've touched upon, you know, the medical conditions that put people at increased risk of RSV and their severe complications. Do you think we should be prioritising these risk groups as well as the ones that are on the NIP? I mean, that's a...
The question is, so the question could be, should we prioritize the high-risk group? So how high is high? And which ones are high? Is cardiac more than COPD? Is, you know, diabetes less than cardiac, and so on? And do we have a shortage of RSV vaccines? I mean, if we had a shortage, clearly we should target the group at highest risk, but how high is high? If we don't have a shortage, we should target the people at risk, which is the elderly, which is, as you currently said, 75, unless you're talking about Indigenous populations. And we're talking about those with comorbidity, particularly multiple comorbidity. So I don't think we should pick out certain comorbidities. Certainly multiple comorbidities, we know, put you at as high a risk as if you were immunocompromised. I mean, that we know. But many people of that age are very likely to have multiple comorbidities. And even in data in Australia, at that age, I can't remember the exact numbers, several of those have 2 or 3 or more. It's not uncommon to find an obese individual who's got hyperlipidemia, who may have cardiac issues, who may be diabetic, and so on. So, I mean, that would be my answer. Ideally, we should target all patients, if we got enough vaccine, target all those who are elderly, and it's now reimbursed from 75, as we said, except. and those who have comorbidity.
Oh, I heard something really interesting this morning. So I knew coming into this meeting that those with chronic lung disease were about 10 times more likely to end up with RSV hospitalisation, and those with asthma, whether they're in the sort of 50 to 64 or 65 to 80 year group, they were 8 times more likely to end up with RSV hospitalisation. And congestive heart failure 5 to 6 times, coronary artery disease 3 to 5 times, diabetes, it was double the risk. And what I was surprised was one of the speakers, and I'm so sorry if it's just all day, my brain's just fried. They mentioned that if you've got a healthy 75-year-old or over 75, they might be at lower risk of some of the complications compared to somebody who was younger but has multiple comorbidities. So it's not as straightforward as we think. So it's really exciting moving forwards. And I know we might have heard some whispers of some positive PBAC recommendations, which I won't go into. But Ralph and Kaz, I know you're chomping at the bit to say something.
You were saying that, 17 times increased risk if you have asthma or COPD to be admitted to hospital. But on top of that, then they have a 40 to 60 times risk of having a heart event. So, it's just not the admission to hospital, it's the exacerbation that actually causes the problem. And now we're talking about this cardiorespiratory nexus, that if you have an exacerbation, your risk of having a heart attack is huge.
Kaz, you look like you had something else to add.
I do. So I think, when we're making these deliberations on ATAGI that are not necessarily driven by PBAC and what the pharmaceutical company has brought forward, the data is really, really clear. And the data was absolutely 100% clear about the older adults being most at risk. The other groups that you're talking about, particularly chronic lung disease, heart disease, diabetes mellitus, yes, there is a risk there at a younger age if you have those conditions. And this was a recommendation, I think, that those groups would be included, recommended to have the vaccine, sadly not funded. But that has to be something that's driven by data plus, whether or not, PBAC will accept those extra groups. Particularly at some point, I think that those groups will be looked at again. And I certainly welcome it, as I'm sure we all do, that those groups will be funded to be vaccinated. But I don't know.
Oh, I might throw that to Charles. Now, that's limited by what's funded. Now, would you still recommend it if patients were willing to privately fund the vaccine or had access to DVA or a patient, family member that was willing to fund their vaccine?
I think what you saw was a particular study. And I could probably bring up, I can't think offhand, if I think of the literature on pneumococcal disease, there's studies that show that COPD is the most important thing, and then other studies show this and that and so on. So I think there are clear-cut risk factors that are much higher. If you look at immunocompromised individuals, those with malignancies, transplant patients, for example, renal failure, those cases are at very high risk. They are at the level of immunocompromise. So targeting one chronic disease, COPD, cardiac versus diabetes and so on, it's all in the same ballpark. Those other things, the immunocompromising things, are far greater. So if, how high is high? The answer is immunocompromised, transplant patients, renal failure. COPD, cardiac, they're all very similar. Some things higher, some things lower. If I could, I believe that you should, that 75 is too high an age to go for. Immunosenescence and inflammaging starts occurring from the age of 50. If you look at pneumococcal vaccine, for example, it started off also the higher age groups. And if you look now, the ACIP, CDC, they are recommending vaccination for pneumococcal disease from the age of 50. So we've come all the way down. And I'd like to think that with all these infections, we've started the low-hanging fruit. But ultimately, we've gone down to lower ages. So I would go down to lower ages. I would like, if I could, to vaccinate people who are younger with comorbid conditions, or maybe, depending on the actual age we're talking about, even without comorbid conditions.
I think that'd be in an ideal world, but that's not actually what the data shows. And I don't think that PBAC or ATAGI just randomly choose groups. That is what the data shows, the groups that are chosen, and 75 is definitely where there is a jump up. In fact, probably even older, in terms of being a cost-benefit situation, which is what, unfortunately, the NIP is.
One question from the audience, from Gail Online. Will health staff at high risk be able to gain free or subsidised vaccines? Presumably for RSV.
No, sadly, I think unless you fit into one of those groups, anyone can get an RSV vaccine if they're over the age group, so it's, but depending on whether it's a Brisva or Arexvy, you're 50 or 60, you can purchase the vaccine, which is extraordinarily expensive, and you'll get 2 to 3 years protection. So you can choose to do that, but it won't be something that's funded because of, it will protect you individually, but will it protect your patients?
So
Probably not.
NIP funded with the Arexvy brand for those who are 75 and over, 60 plus if you're Indigenous and Torres Strait Islander population. But otherwise it will be privately funded, and Arexvy is indicated from 50 plus, Abrysvo is 60 plus. So just make sure you don't get the age group wrong. We have 2 minutes left. Any questions from the audience? We'll pass you the microphone first, just so our online audience can hear.
While we're waiting, one thing I do have, we've got a nice panel here, nurse practitioners and pharmacists. One of the things, it's been great to have the access for my patients to all these vaccines, but I can no longer do a search on my database to find out who's had what. So, I used to be able to go 65 over, end of May, I'll do a search for all my flu vaccines. But of course, when I do my search now, it's only the vaccines I've given. And of course, you send out all these reminders, all these people come in, well, doctor, it was given to me. Why don't you know? And so we've stopped doing it.
You can actually get that data via a HPOS report.
Can you?
Yeah, you can.
Because last time I tried to phone up, they said, no, you can't get it.
Yeah, it's a tricky business, and it's the entire
Because
needs a review.
All right, we've got the microphone over here. Oh, hang on, just make sure you speak into the microphone so our online audience can hear. Sorry.
Heard repeatedly.
Sorry, we've heard repeatedly.
The over 75 age group is a very difficult group to people when it comes to the vaccination failure. I'm a GP and I look after a lot of these 75 years old concentrated in nursing homes. The problem we are having is actually, you go to the nursing home, you carry all your vaccines and go and tell the nurse, I've got so much in my bag there now, I want to vaccinate all my over 75. You can't, doctor, because we haven't got the consent from the family. So then you tell them, the manager or the CCM or whoever the person who is responsible, get the list, get the signature, and keep it ready. I am coming on the next Friday to vaccinate. And this never happens. So this is one of the very important reason, the vaccination failure, because most of these over 75 people are concentrated in nursing homes, and any GP who is visiting these nursing homes will probably find the same problem. And I have a large collection of them. I probably must have vaccinated about 10 in the last 3-4 weeks. Wow. Although I have got such a collection, about 30 vaccines in my bag I carry, no consent. So you have to take some action to write to this management of the nursing homes that it is vital that you get this consent from the guardian or whoever the person and keep it ready.
Thank
Whether
you for
get to do that one at the admission or at the vaccination time when the vaccines are ready, that must be done. Then it will happen. Otherwise, it never happens.
Thank you. That is such a common theme that I hear from our healthcare professionals who visit nursing homes, whether it be GPs. Now, we've got Haveen, who's actually scheduled to go to a nursing home tomorrow to give RSV, and she's going to make it her RSV day. So how do you, and we'll wrap up with that as the last question because I'm mindful it's 9 o'clock. So how do you handle that? Is your approach different?
I don't think it's that different. You just have to be really organised. You got to be. No, I'm not kidding. So you have to touch base with the nursing home at least 3 to 4 times prior to your clinic day. You have to create relationships with the nursing home and the right staff, so things get done for you. And I mean the right staff. We have about over 75 people booked in tomorrow, and every single person has a consent form. Every person is booked into our practitioner app. So everything that gets done on the spot will also get uploaded onto air. Now, we don't have a state-of-the-art program, but it does the job. But consent, I agree. I had to go through the really hard way of learning that that is the most important piece. And I used to also visit nursing homes where I had, 15 to 16 patients. But I had over 50 vaccines in my fridge. It didn't work. And I learned that I have to follow up and I have to ensure that they've gained consent, they've been booked in, and then we attend. So it is a collaborative exercise that requires, many people. So it requires the nursing home to be organised, it requires the pharmacy to follow up, it requires us to be checking air constantly to make sure that they're actually eligible for it, and family members. And I have had a few, residents that would come in and will say, I want to get a vaccine today. You don't have consent, okay? Then we end up on the phone getting the family members, what are they getting? They're getting their, influenza, or they're getting their COVID. So, you chop and change, but the most important thing is to make sure that you've got a contact at these nursing homes that has to do a lot of that work for you.
So we've come a long way in 12 months from our last meeting, where we can see we've got a lot more robust data. We knew it worked, but now we can show people that it's safe, it's effective, but it won't work if we have these vaccines but they're not in people's arms. We need relationships. We've heard from Christine McCartney at the Theory Oration that we need truth, we need trust. And it'll be interesting to hear what progress we make in the next 12 months to come. Thank you very much. What I'll do is have you join me in thanking all our panel members, and I'll welcome Hannah back to the stage to close our session.